Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I turn to Dr. Tom Inglesby, Director of the Johns Hopkins Center for Health Security, to answer some questions we've received from listeners through our email address, publichealthquestion@jhu.edu. Let's listen. Dr. Inglesby, thank you very much for joining for another Q&A episode. Are you ready?
I'm ready. Good to be with you.
So the first question has to do with universities, which are opening to greater or lesser success against the coronavirus. What are you seeing that is important? And what do you think, what lessons are coming up in the early days here?
Yeah. So the first thing is that it doesn't look yet like it's being systematically studied. So these are all going to be based on anecdotes and observations. Hopefully it is going to get more systematically studied so that we'll learn a lot, so that the second semester of college this year will know more than we do when we're starting. But some things that seem likely are that colleges or universities in places of high incidence are going to be at higher risk. So for example, the Northeast has many colleges and universities in places where the incidence is very low, and I think they're starting off at an advantage. The second thing is that some colleges that are relatively self-contained have taken a strategy of really kind of trying to create a quasi-bubble. Nothing's a real bubble because they're interacting with people who live there and take care of them in college, but they're trying to really kind of keep the kids from kind of leaving campus. That might be useful. It's too soon to say, but that might help. It's also true that some colleges have had a strategy of only testing symptomatic people as compared to others who are testing up everyone upon arrival and then multiple times in a week. We don't know yet which of those strategies will work. There are good and bad examples in each category. My instinct is that more testing will produce better results, but only if coupled with pretty careful masking and social distancing requirements in the absence of large gatherings. There have been some colleges that we've seen open without any kind of testing strategy and loose approaches to gatherings, and that doesn't seem to last very long. That seems like that is going to be something we see that hopefully won't continue because it's not going to work.
In terms of testing, one other question. There's been a lot of articles written about the idea of switching to rapid tests that may not be as accurate as the usual viral tests, but could be done much more frequently. Do you think that is something we're going to start seeing in the United States, that we'll be testing ourselves multiple times a week and that'll allow us to do more things?
I think it's possible. We're not there yet in terms of the technology getting through FDA or coming to market. We're kind of a step of the way there with all of these rapid antigen testing options that are coming online, but those still require a device and somebody who's trained to use that device. It's possible to get those kinds of devices and that kind of testing going in large institutions at this point. And I do think that we will begin to start using rapid antigen tests, both because they're less expensive and very widely available. Millions of tests are going to be available per month. Tens of millions of tests will be available per month in this fall, with many of the major diagnostic testing companies providing an option. Whether we actually get to the point of home testing, like we could do, for example, with home pregnancy testing, a kind of a paper-based yes or no, I'm contagious or I'm not contagious. I think that is a technological aspiration and it's possible. I think the technology does exist, but whether it can get through the FDA approval process, whether it can be validated, whether the business model works, I think we're still discovering that, but it's a possibility. And the high side, as you said, would be that we first of all, less money per test. The test is closer to the person. The turnaround time is 15 minutes, as opposed to waiting 1 day, 2 day, perhaps many days for a PCR test. And so because of that, it could be done multiple times, maybe once a day for a few days in a row or a few times a week. And the other potential advantage is that it's a test that becomes positive when people are likely at their most contagious. And so it might help us as a test of not only telling whether someone's positive, but also telling whether somebody is positive and contagious, and so is therefore at high risk and really needs to stay home.
So it sounds like could play an important role, and
Yes.
We're certainly going to try if all those tests are becoming available, but we'll have to see what happens.
Exactly. How it fits into the bigger concept of operations of testing for the country, I think we don't have that worked out, but I think it's going to get a big try.
Great. One last question about testing. The difference between the tests where it feels like a brain biopsy, where it's going all the way up your nose, and the tests that are sort of in the mid part to bottom part of your nose. Why are there two types of swabs like that?
It's because of how the test was developed and what kind of sample is required for accuracy of that test. And so, the test that people, know about and dread the most is the test, the deep nasopharyngeal swabs, which really go all the way back to the back of your nose until they kind of hit the resistance in the back of your nose. And those are, and then required to spin it for a period of time. You really need to get a deep sample for that test to be accurate, that PCR test to be accurate, as opposed to some of the point of care or rapid antigen tests that we just talked about. Some of those only require a sample from the very front of your nose, and just kind of a little cotton swab is sufficient for that. And there'd be no advantage to that test for kind of, going to the back of your nose like that. So there really are two different approaches to tests, and one is, they're both required, but one's much more uncomfortable, obviously. So
it really depends on the test that's being done.
Exactly.
It's not the patient preference.
Not at all. Unfortunately, no. It's the test. It's how it was developed, and it was approved by FDA, and how the technologists set it up in the first place.
Can asymptomatic people experience heart and lung damage or other long-term health issues?
We are still learning about this. I think at this point, there's not a lot of information. We have some small studies which have looked at people's cardiac function with MRI scans to see if asymptomatic people, in fact, got inflammation of their heart. And in one small study, we see that some people do seem to have abnormalities on their MRI scan, even if they were asymptomatic. This was a study of athletes who either had mild infection or asymptomatic infection. But there haven't been larger studies looking at lots of people over time who are asymptomatic. So we're going to need to learn more about that. Hopefully that won't be a major concern, but I think it's too soon to say. We do see that people who were sick from COVID and who are, basically, long-term recovered from COVID, their COVID infection is past. There are some people who have persistent symptoms and disability from the illness, even though their viral infection is over.
Here's a question about the positivity rate as a metric. Very few places are testing entire populations. So if only some people are being tested, what does the positivity rate really tell us? How do you use the positivity rate now in assessing the spread in a community?
Yeah, it's an imperfect test. Many of the tests that we have, I think, need to be combined to get a picture of what's going on in any given community. And if you could certainly game the system if you only did 20 tests in a day, and then you may not have any positives, and would be obviously very false reassurance. But if a state or a county or a city was doing a substantial amount of testing and was basically consistent with the amount of testing it was doing week in, week out, then the percent positive, it's the trend over time that really matters. So week 1, you have a 2% positive, and week 2, you have twice that or 3 times that. That's a serious cause of concern. That is what we think is an early indicator of a rising epidemic. Even if you don't know exactly how big it's going to be, you see that there's a change afoot. So I think the absolute numbers, we hope that they're overall low. less than 5%, but the specific number is less important than the trend itself over time.
So really look at the trend.
Yes, look at the trend. And it needs to be combined with, first of all, substantial testing in a given state or community, because you need to understand, it should be combined with an understanding of the overall incidence of the disease. So how many cases per day per 100,000? Those are kind of companion measures, percent positivity and incidence. And together they give you a better sample than either one alone.
Here's a question about K-12 schools. The question has to do with if someone is symptomatic in a school and is being sent home for testing from a class, do you think that the entire class should be kept home until the test result comes back?
It's difficult to make universal rules about that because classroom sizes are different, classroom spacing is different, whether people are wearing masks, 100% of the time is different. I think, some schools have, 8 kids in a classroom that's massive, and other schools can't afford to do that and have a lot more density and spacing. And so it's going to require the judgment of the leaders of that school together with local public health agencies to make that call. They may decide that the entire classroom should go out together until, if the test is positive, then for the entire 2-week quarantine period. I think my own view is that if a child has symptoms and hasn't had a positive test, but the positive test is going to come back quickly, I don't think that everyone needs to go out every time someone has a symptom of COVID, but should be prepared to go out on quarantine if that test comes back positive.
So that was going to be my follow-up question. So if it actually does come back positive, you would suggest that at least the children who are in that small group would also be sent home until the end of the quarantine period?
I think anyone is considered a close contact, and I would presume that if people are in a classroom together interacting, that probably in most cases they're going to be considered close contacts unless there's a lot of spacing or it's happening partly outdoors or some other mitigating circumstance. But I think presumably if a cohort can be defined like a classroom, then I presume that local health officials and the school itself are likely to consider those people close contacts and they should go home for 2 weeks.
Got it. Now, a couple more questions. One more in the school setting. If somebody starts to feel a little sick Friday night, gets a fever, cough, Saturday, Sunday, but then feels better on Monday, but they haven't gotten a test, do you think they can safely assume they didn't have coronavirus and are doing okay?
Unfortunately not. Coronavirus is the range of symptoms and signs from coronavirus is so broad. And we know that a substantial number of people have no symptoms at all. Other people have mild illness. And then, of course, some people have severe illness. So if you have those symptoms that could be consistent with coronavirus and they get better, you should not presume that you're better and you didn't have coronavirus. I think you should still get tested.
We have last questions here. People looking forward to some seasonal activities, trick-or-treating and caroling, both of which happen outside. Are you concerned about those activities? Do you think extra precautions this year?
Well, with caroling, I think it would need to be done in a way where people were really spaced out pretty substantially. The good news is it's outside, and outside is far safer than inside. But we do know that infections do occur outside. They're just occur at a much, much lower number than inside. And unfortunately, singing is, as wonderful singing is in the holidays, singing is an activity which we know increases the virus or the potential for virus to be spread. Not in everyone, but certainly in some people who've gone on to create super spreading events, for example, in churches or choirs. And so I think if people were going to be singing together, I think it would need to be very spaced out. So the kind of close in Christmas caroling that we would normally might see in a community, I think that is going to be high risk.
What about trick-or-treating?
I think trick-or-treating, if people are in their own small cohorts, your family members are together and are wearing masks and are away from other people who are out moving around in the way that we would kind of avoid people moving around in a normal day. And if they are not closely interacting at people's doors, but could kind of be out, maybe people could lay their, I haven't thought about this much yet since we haven't gotten there yet, but if people could put candy out on their step and not, kind of diminish the interactions, I think there could be ways to do this with lower risk.
I think there'll be a lot more costumes that already have masks involved in them.
That's probably true. There probably will be many masks, and I think that's a good thing.
Batman comes to mind.
Yeah, although Batman doesn't have a face mask, he has an eye mask, right? I think Batman would need. Maybe he does. I don't remember.
No, I think you might be right. We have to double check for next time.
Yeah.
Thank you so much for joining me to answer some of our listener questions.
Thanks a lot, Josh.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.